Good afternoon, everybody, and welcome to this ERKNet webinar. My name is Tanja Blodkowski, and I'm speaking from the ERKNet Central Office in Heidelberg. Before we start, let me remind you that your microphones are turned off, but during and after the webinar, you are able to ask questions through your participant panel on your screen. Our speaker for today is Dr. Aude Servais from Paris. She is a senior nephrologist at the Department of Adult Nephrology at Necker Hospital. She is a referent in adult nephrology in the Reference Center for Children and Adult Hereditary Renal Diseases. Her research interests include genetics of focal segmental glomerulonephritis, management of cystinosis in adolescents and adults, and C3 glomerulonephritis. She has authored more than 50 research articles in peer-reviewed journals. So, Aude, please start your presentation.
Good afternoon. We will talk today about APOL1 risk genotype in FSGS and other nephropathies. As you may know, there is a black and white disequilibrium in the United States. African Americans have a fourfold increase of risk of end-stage renal disease. They represent 13% of the general population in the United States, but 1/3 of the end-stage renal disease population and half of the hypertensive attributed end-stage renal disease. 10 years ago, a locus on chromosome 22 was identified as associated with FSGS, HIV-associated nephropathy, non-diabetic end-stage renal disease, and hypertensive end-stage renal disease. First, the gene MYH9 was involved, but finally, it is the APOL1 gene who is concerned by this problem. It is encoding for APOL1 protein. In the initial publication, FSGS and hypertension attributed end-stage renal disease were associated with two risk alleles of APOL1 in patients of African American origin. They are called G1 and G2, and G1 and G2 are exclusive, never occurring on the same chromosome. The association was true at the homozygous or compound heterozygous state, which is corresponding to a recessive pattern of inheritance. What is APOL1? APOL1 is a human trypanolytic factor which confers a resistance to Trypanosoma brucei, which is one of the causes of sleeping sickness. In vitro, only the kidney disease-associated APOL1 variant is able to release Trypanosoma brucei rhodesiense, which is responsible for the human disease. So, we think that APOL1 gene may have undergone a natural selective pressure in Western Africa. You can see here the frequency in the normal population of APOL1, G1, and G2 risk allele is very high here in West Africa and especially in Nigeria. But it's also very high in African American and in the Caribbean population who are coming from West Africa. It is also present in Brazil. In Caucasian population in Europe and the United States, the risk frequency is very, very low. So in the general population of African American, 30% of people have one high risk allele at the homozygous or compound heterozygous state. But when we focus on FS in these three initial publications, you can see that between 66 to 72% of patients have this high risk allele, which is significantly more than in the control group. If we focus on HIV-associated nephropathy, the odds ratio is much higher, around 30, with a very strong association with APOL1 high-risk allele and HIV-associated nephropathy in African American. Then it was studied in other disease, in hypertensive and stage renal disease patients. The association was also true in hypertensive chronic kidney disease, and then also in end-stage renal disease of any etiology. Two other diseases are very interesting. The first one is sickle cell disease. There are two studies, the first one from the United States and the other one from France. And in this disease, there is an association with APOL1 high-risk allele and the risk to develop proteinuria and to develop renal failure. Then the last disease, which is very interesting, is lupus. And in lupus, there is a strong association between the risk to develop end-stage renal disease and APOL1 high-risk allele, and also the risk to develop a rare kind of lupus nephropathy, which is collapsing glomerulonephritis. In the initial publication of FSGS and APOL1, you can see on a clinical point of view that the age at onset of the disease tends to be at a younger age, here in red, and at a narrower onset age range, since 70% of cases are presenting between 15 and 39 years of age. Here, the population of patients with APOL1 low-risk allele. Then we ask the question if this was also true in Europe and especially in France in patients originating from Africa. And we studied 152 patients in 139 families presenting with FSGS or steroid-resistant nephrotic syndrome and originating from Africa. And in this population of patients, we found high-risk genotype in 43% of patients, which is significantly higher than in a control population of African origin. Interestingly, the high-risk genotype is frequent around 60% of patients if they are originating from French West Indies, like in African America. But in patients originating from other parts of Africa, the frequency was lower, but it was still significant. Then the next question was, is this APOL1 high-risk allele associated with other mutation in non-monogenic steroid-resistant nephrotic syndrome genes? So we screened all these patients for these other monogenic steroid-resistant nephrotic syndrome genes. And we found a mutation in 17 patients, but only in one patient with the APOL1 high-risk allele group. And this patient was very particular since he was presenting with congenital nephrotic syndrome, and we found, as expected, a compound heterozygous mutation in NPHS1. Then all the other mutations were found in patients with APOL1 low-risk group. We then analyzed the clinical presentation of the patients. If we divide the patient into groups, the APOL1 high-risk group and the APOL1 low-risk group, you can see here that in the APOL1 high-risk group, 41% of patients have a familial disease, which is significantly higher than in APOL1 low-risk group. So they have a familial disease, but we cannot find any other causative mutation. Age at onset is higher in this population in the APOL1 high-risk group, with a mean age at onset of 22 years. And a little bit more than half of the patients are adults at presentation. If we look at the age at onset of proteinuria according to APOL1, you can see here in blue all the APOL1 high-risk patients. Of course, a lot of them are presenting in young adult age between 18 and 40 or 50 years of age. But there is also a large proportion of patients presenting in childhood from 6 to 70 years. As expected, the patient presenting with a mutation in monogenic genes are found in very young patients. At presentation, patients with APOL1 high-risk allele also have a lower eGFR than patients in the APOL1 low-risk group. The next question is the treatment for this patient. In the initial publication, it was said that the sensibility to glucocorticoid in African American was similar in APOL1 high-risk patients and in APOL1 low-risk patients, with a sensibility around 30%. But as you can see here, there are very few patients, so it's very difficult to analyze this data. In our study, all patients in the high-risk group were steroid resistant, but also a large proportion of patients in the low-risk group were steroid resistant, and it is because these patients were addressed to our department for genetic screening because of steroid resistance. So there is a barrier here. If we analyze next the remission score after other immunosuppressive treatment, there is a publication of the FSGS clinical trial in which APOL1 status was analyzed, and you can see here that the remission score after corticosteroid treatment or mycophenolate mofetil treatment was not modified by APOL1 genotype. So in this study, all patients have a similar remission score. However, in the Neptune study, which is a large cohort of patients who have a nephrotic syndrome, but of any cause, which is quite difficult for interpretation, you can see here that the APOL1 high-risk genotype is associated with a 70% reduction in the probability of complete remission at any time, and this was independent of histological diagnosis. So the prognosis after treatment is poorer in this APOL1 high-risk patient than in the other one. And more recently, a very interesting study analyzed APOL1 in corticosensitive nephrotic syndrome. This is a cohort of 115 African American children. 75 of them are corticosensitive and 50 are corticoresistant. As you can see, APOL1 high-risk allele is not associated with corticosensitive nephrotic syndrome. So the frequency of APOL1 high-risk allele in the corticosensitive patient is similar to general population. But as expected, there is a significant association to corticoresistant nephrotic syndrome. So probably these patients have more frequently corticoresistant nephrotic syndrome than corticosensitive nephrotic syndrome. And then what is the evolution of the patient? In our study, GFR at last follow-up was lower in APOL1 high-risk group than patient here in the APOL1 low-risk group. Renal survival tended to be worse in APOL1 high-risk group here in blue compared to a low-risk group, but it didn't reach significance. But in the initial publication from COP, renal survival in FSGS was here very significantly decreased in patients with 2 risk allele compared with patients with 0 or 1 risk allele. If we look at renal survival in another glomerular disease, which is HIV-associated nephropathy, once again, the renal survival is worse in patients here in red with APOL1 high-risk allele. There was also a very big study which looked at APOL1 risk variants in 693 patients in the ASK study. These are patients with chronic kidney disease attributed to hypertension, and the primary endpoint was doubling of serum creatinine or reaching end-stage renal disease, with a long follow-up. And in this very large cohort, you can see here that APOL1 high-risk patients with 2 copies of APOL1 risk variants have higher risk to reach primary endpoint compared to the other patients. if we look at a very large cohort of 3,000 young adults, which is called cardiac study, this is a cohort of healthy patients who are followed for a long time. And you can see here that high-risk allele Black patient developed here proteinuria at a younger age than low-risk Black and then Caucasian. And then some of these patients developed chronic kidney failure, and the slope here of the decrease of eGFR is higher than in the other patients. Then age at dialysis has been also studied according to APOL1 status, and you can see here that patients with G1G1 or G1G2 or G2G2 APOL1 high risk allele reach end-stage renal disease and dialysis at a younger age than other patients. Then when these patients reach end-stage renal disease, of course, and we speak about transplantation, the allograft survival after transplantation has been studied. In this first study, allograft survival was analyzed according to recipient genotype. As you can see here, there is no genotype on allograft survival. So, of course, some of analyzed APOL1 risk allele and donor, kidney donor status and renal graft survival. And as you can see here, APOL1 high risk allele donors are there in these donors, the allograft survival is worse than in the non-risk allele patients. The difference is significant here after around 20 months of transplantation, and some patients have been biopsied, and on biopsy, the authors found some FSGS lesions or arteriosclerosis. Then there are other publications which analyze this data, and with a larger group of patients. This is a large publication of the impact of APOL1 risk allele in donors and impact of allograft survival. Here you have around 600 patients. And once again, as you can see, APOL1 high risk allele donors induce a lower allograft survival than patients receive APOL1 low risk allele kidney. Of course, this is significant, but probably from a clinical point of view, the difference is quite low. But recently, another kind of manifestation has been published. This is a large study of de novo collapsing FSGS after transplantation. And the authors found that in these patients who develop collapsing FSGS after transplantation, 47% of patients
Sorry, Aude, I think the audience cannot hear you. Can you check your microphone, please? Aude? I think we are just having some trouble with the connection, so please hold on for a second. Aude, if you can hear me. Yeah?
Yes, I can hear you. Yes, do you hear me?
Yes, now you are back with the microphone. Okay, so we can go on.
But I didn't change anything, I'm sorry.
I don't know.
So I go on?
No, so everybody is still here, so please go on. No problem.
I'm really sorry, I didn't change anything, sorry. So we were speaking about collapsing FSGS after transplantation. And I was just saying that 47% of this patient who developed collapsing FSGS after transplantation get a kidney from an African donors, including 53% of these donors were APOL1 high-risk allele. And then renal allograft survival is really decreased in this patient with developed collapsing FSGS after transplantation, and this risk of losing the kidney is much higher here in APOL1 high-risk allele donors. The next very important question is the question of living donors. As you all know, living donors have a lower risk to develop end-stage renal disease than in the general population. But if we compare living donor to very healthy non-donors who could have given their kidney, there is an increased risk to develop once end-stage renal disease. And this phenomenon is very important in Black donors. Here you can see the risk to develop end-stage renal disease in Black men and Black women, which is much higher than in white men and white women. And in these Black donors, the risk is higher in young donors, here between 33 and 44 years, and here below 35, than in older donors, which is quite different from Caucasian donors. Then there are two cases reported in the literature of living donors who were APOL1 high-risk allele who developed FSGS and renal failure after donation. One of this family, in here, you have two twin brothers. One developed FSGS and was given a kidney by his twin brother. But very quickly, their eGFR were decreased, and he loses his kidney after 5 years of transplantation, and here is the proteinuria, which increased. And the donor had, of course, normal renal function at donation and no proteinuria, but then he developed proteinuria, and also he developed chronic kidney dysfunction. So after this story, the authors diagnosed APOL1 high-risk allele in both brothers. Last year, a large cohort of 136 donors was published with a long follow-up of 12 years. 78% of these donors were first-degree relatives to their recipients, but the risk allele frequency was comparable to the general population in these donors. And here we can see the eGFR in the low-risk patient, in the high-risk APOL1 patients before donation, and here after donation. And as you can see, there is a 10 milliliter minutes difference, even before donation, but also after donation, between these two groups of patients. And 2 patients in the high-risk group develop end-stage renal disease after donation. And the other patient in the high-risk group had a lower eGFR after donation than in the low-risk group, which a large proportion of patients with eGFR between 45 and 60 milliliter per minute, and even lower than 45 milliliter per minute. Then the authors compared the rate of decline of post-donation eGFR and found that this rate of decline was greater here in high-risk APOL1 genotype donors than in the low-risk APOL1 genotype donors. And then they compared, it's here, they compared to the general population of non-donors according to APOL1 genotype. They took some patients from the cardiac study, and you can see here that there is a similar rate of decline in eGFR between donors and non-donors, but the rate of decline is different in the high-risk APOL1 patient and in the low-risk APOL1 genotype patients. Just 2 slides to show you that APOL1 high risk is probably not the only thing that could explain the higher risk in Black donors. In our hospital, we analyzed low-risk donors, and we compared these low-risk donors of African origin to Caucasian donors. And we analyzed the functional gain, which is defined by the difference between eGFR 1 year after donation and eGFR 1 year or GFR just before donation of the remaining kidney. And as you can see here, the absolute functional gain is lower in APOL1 low-risk African origin donors compared to Caucasian. Then this could be due to lower total renal volume and a total lower remaining kidney volume. So even low-risk APOL1 donors may have a lower compensatory response of the remaining kidney compared to Caucasian donors. So then, which are the mechanisms of the toxicity of APOL1? We know now more and more detail on this. Just here is a summary of what we know. Is trypanosome, is the renal cell, and probably, of course, the mechanisms are similar. We know that there is an increase of endocytotic activity, a reduce of acidification of the endosome, and an alteration of the endosomal pathways. There is an accumulation of autophagosome and also a mitochondrial defect. And all this trouble lead to a cell death. So to conclude, the 2' allele APOL1 genotype is frequent in FSGS patients with African ancestry. It's a young adult disease, but also found in children. It is associated with a poor renal survival. This is a familial disease and not associated with other mutations in non-monogenic steroid-resistant nephrotic syndrome gene. The risk of renal failure after kidney donation is important, and we have to investigate on that point. So I would like just to thank all the team I'm working with in the genetic laboratory of Corinne Antignac and Necker and all the nephrologists I'm working with. And I'd like to introduce the next webinar, which is a webinar from Jan Becker from Germany. He will talk about histopathology of antibody-mediated rejection on the 9th of April. Thank you very much for your attention.
Thank you very much, Aude, for your presentation. And I think you have prepared some multiple choice questions. So please now you will have the time to answer on these questions. I will just show the first one and you can start to read it. You can see the questions, Aude?
Okay, yes. So the first question was, which kind of nephropathies are associated with APOL1?
Correct. So please vote.
That's it?
Yes. And maybe you could read the possible answers.
So hypertensive nephropathy, diabetic nephropathy, HIV-associated nephropathy, FSGS, or IgA nephropathy.
Okay, we will just wait one more seconds to let the audience vote. Okay, I will close the question and show the results, and you can comment.
So you are very good. Of course, it is associated with hypertensive nephropathy. It is not associated with diabetic nephropathy. There are some negative studies on this point. It is associated, and the association is very strong with HIV-associated nephropathy, and is associated with FSGS. There is no association at this time with IgA nephropathy. So it was quite simple. Okay. Then the next question.
Mm-hmm. I will start the next question right now.
So this APOL1 associated FSGS starting at which age? It's a disease of young adult, of adolescent, of children, or both adults and children. Young adult, not young adult. There's a spelling mistake. It's young adults and children. The next question.
So please vote. Okay, I will close the question and show the results.
So I would say more or less all the questions are through, but I would say it's a young adult and children disease. First, it was demonstrated that it was a young adult disease, but in our study, we have shown that there are also many children, not very young children, but starting from 6 years of age, there are a big proportion of children also. So it's not only a young adult disease.
Okay.
So now the next question.
Mm-hmm. We'll start now.
Can we find some mutation in monogenic steroid-resistant genes associated with APOL1 high-risk allele?
So, okay, I will close.
So the answer is more or less no. The only study in which this has been addressed is our study, but it's a large study, including many children. So the APOL1 high-risk allele was not associated with other mutation. We had only one case with this association, and this case was a congenital nephrotic syndrome patient, so it was not very strange to find a mutation in NPHS1. But most of the time, APOL1 high-risk allele by itself can explain probably the development of FSGS. So then the next question.
The next and the last one is open now.
So the last question was, is APOL1 high-risk allele kidney donors, are they at increased risk of end-stage renal disease after donation? This is very simple.
So let's close the question.
So most of you answered yes. Yes, I think we have now some strong data showing that there is an increased risk after donation. Of course, we don't know yet what to do with this donator, but there is an higher risk and it should be taken in consideration.
Okay, this was your last multiple choice question.
Yes.
And we have received 2 messages, one from Teresa Santos, who would like to thank you for your presentation. And actually one question from Carmine Pecoraro, who is asking which is the frequency of syndromic forms of collapsing glomerulopathy APOL1 associated.
Syndromic, I think you mean associated with extrarenal symptoms. So all these APOL1 patients had a non-syndromic presentation of FSGS. So there was only the renal disease. And then the second part of the question is the histological form of FSGS. And in our cohort, there was not a majority of collapsing FSGS in the APOL1 high-risk patients compared to the others. Of course, we have not so many patients, so maybe it's difficult to have a statistical significance, but we didn't find a higher frequency of collapsing compared to other forms of FSGS, but we had a lower frequency of minimal change. This is on renal biopsy for this patient with APOL1 high-risk allele.
Okay, thank you very much, Aude. I have no other question right now. So please ask your question. You can use your control panel and I will read them for you. So Aude, I cannot receive any other questions. You would like to add something on your presentation or?
Right now, maybe APOL1 analysis should be added to other gen analysis in this patient presenting with FSGS. And in our department now, it is in our panel, genetic panel for FSGS.
Okay, thank you very much. So we will wait 1 more minute. Please don't be shy. Ask your question if you have any to Dr. Aude Servais. Mm. It seems that everybody is happy with your presentation. So I think we should come to the end of the webinar. Thank you all for your attention, and thank you, Aude, for this great lecture. And I would like to say thank you to all again and have a good afternoon. The webinar is closed.
Good afternoon.